Welcome to this rapid-fire explainer where we are absolutely sprinting through some high-yield trauma and wound management concepts.
Let's dive right in and test your clinical knowledge.
Question 31. What's the best treatment for a linear hypertrophic scar at 8 weeks post-injury? Is it A, surgical excision, B, radiation therapy, C, intralesional steroid injection, D, pressure therapy, or E, none?
All right, the correct answer is D. At 8 weeks, you've got to remember that a scar is still totally immature and active. Because of this, your first-line management is strictly conservative. We're talking pressure therapy combined with silicone gel to actively reduce vascularity, promote collagen reorganization, and really flatten that scar out. You absolutely want to reserve surgery or injections for mature, resistant scars.
Question 32. An injury limited strictly to the epidermis is called what? A, an abrasion, B, a laceration, C, a contusion, D, an incised wound, or E, none.
The answer is A, an abrasion. This is literally the most superficial traumatic skin injury you can get. It's strictly due to friction, which limits the damage just to the epidermis. This sharply sets it apart from lacerations, which actually tear into the deeper layers, or contusions, where you have completely intact skin sitting over subcutaneous bleeding.
Question 33. Blue discoloration after trauma with intact skin is A, abrasion, B, laceration, C, bruise or contusion, D, incised wound, or E, none.
Got your answer? It's C. Intact skin over ruptured subdermal capillaries creates a contusion. And here is a massive exam pearl for you. As the hemoglobin breaks down, it predictably shifts colors. It goes from an initial red phase into an early blue or purple, then green, and finally fades out to yellow.
Question 34. A knife attack most likely produces what kind of wound? A, a contusion, B, an abrasion, C, a stab wound, D, a friction burn, or E, a chopping wound.
The correct answer is C. The defining mechanical feature of a stab wound, like one produced by thrusting a sharp object such as a knife, is that its depth actually penetrates deeper than its surface length. Just for contrast, trauma from heavy weapons, like an axe, produces a chopping wound instead.
Question 35. What is the expected finding at a 1.5 feet firearm injury? A, a stellate wound, B, a lacerated wound with soot, C, a 3 to 5 centimeter laceration, D, a round wound, or E, a cookie cutter effect.
The answer is D. You have to remember that firing distance radically alters wound morphology. A near shot, say at roughly 1 to 2 feet, produces a circular or round wound. You'll see minimal to no soot, though you might actually see some tattooing. A direct contact shot, on the other hand, produces a stellate wound, and a shotgun blast notoriously creates what we call a cookie cutter effect.
Question 36. What's the best management for a delayed contaminated wound at the 12-hour mark? Is it A, debridement plus open dressing, B, primary suturing, C, a skin graft, D, flap coverage, or E, none?
The correct answer is A. Listen, sealing a delayed, contaminated wound past that 12-hour mark is just inviting disaster. You absolutely cannot do a primary closure here. The initial management protocol strictly mandates thorough debridement, high-volume irrigation, and open wound care. You can eventually follow that up with delayed primary closure or secondary reconstruction, but not right away.
Question 37. What is the most important step right after a hand infection debridement? A, elevation, B, heavy dressing, C, no effective elbow position, D, no immobilization, or E, none.
The correct answer is A. Immediately following debridement, that hand must be aggressively elevated above heart level and strictly immobilized. You are mechanically fighting gravity here, and that reduces harmful edema, improves venous drainage, and dramatically enhances both wound healing and pain control for the patient.
Question 38. What is the most likely site of a bed sore in a wheelchair patient? A, occiput, B, sacrum, C, greater trochanter, D, heel, or E, ischium?
All right, the answer is E. Think about the biomechanics here. A seated wheelchair posture directs the body's maximum pressure vertically, right onto the ischial tuberosities. In contrast, if you have a flat, bedbound patient, they experience the most risk at the sacrum and heels, and a laterally positioned patient risks skin breakdown at the greater trochanter.
Question 39. What is the initial prevention strategy for pressure sores? A. Surgical debridement. B. A vacuum dressing. C. A duoderm dressing. D. IV antibiotics. Or E. An air mattress.
The correct answer is E. The undisputed absolute foundation of pressure sore prevention is proactive pressure offloading. This relies strictly on using air or foam mattresses, regular 2-hourly repositioning, and consistent weight relief maneuvers. Surgery and aggressive interventions, those are reserved exclusively for advanced, high-grade ulcers.
So, will committing these specific clinical patterns to memory be the exact edge you need to master your trauma and wound care boards? Use these pearls to lock down the facts, refine your clinical intuition, and literally leave no room for guessing on exam day. Keep analyzing and keep learning.